This is Robyn Horsager, and I'm a maternal fetal medicine specialist at UT Southwestern. I'm going to talk a little about the diagnosis and treatment of hypertensive disorders in pregnancy. Why does the management of hypertension matter in obstetric patients? In 2016, a journal published a report that suggested the rate of maternal mortality had doubled in Texas between the years 2010 and 2014. It turned out the report was not completely accurate, and the rate was falsely elevated due to errors in death certificate completion. The review performed on maternal deaths in the state of Texas provided some very specific information on causes of those deaths. Hypertensive disorders complicate about 5 to 10% of all pregnancies. In this review, hypertension or hypertensive disorders were responsible for about 5% of all maternal deaths in Texas. In the United States, hypertension is responsible for 7 to 8% of all maternal deaths. Importantly, as many as 1/2 of those deaths are felt to be preventable. The graph demonstrates the increasing prevalence of hypertensive disorders during pregnancy. Young women and women in their first pregnancy are more susceptible to developing preeclampsia, while older women are at greater risk for having chronic hypertension and superimposed preeclampsia. Importantly, the graph also shows the contribution race and ethnicity play in these disorders. Black women have a much higher rate of hypertensive disorders when compared to other groups. Let's review some definitions and diagnostic criteria for hypertensive disorders in pregnancy. First, hypertension is defined as persistent blood pressure measurements greater than or equal to 140 millimeters of mercury systolic or 90 millimeters of mercury diastolic. If you trained in the past, you may recall hearing about a criteria that looked at the absolute change in blood pressure compared to the patient's own baseline blood pressure. That is no longer used to define hypertension. Severe hypertension is defined by a systolic blood pressure greater than or equal to 160 or a diastolic blood pressure greater than or equal to 110. Gestational hypertension is the presence of hypertension that appears in the last half of pregnancy. It is not associated with other organ involvement. Specifically, no proteinuria is present. With preeclampsia, the hypertension is associated with other organ involvement, like the kidneys or the liver. 5 to 8% of women in the U.S. develop preeclampsia. If a patient develops seizure activity, we classify them as having eclampsia. Eclampsia is not limited to the period around delivery. 10% of women who develop seizures will do so more than 48 hours after delivery. Women are classified as having chronic hypertension if they have a history of hypertension prior to the pregnancy or if they have elevated blood pressures in the first half of pregnancy. If you're seeing a woman for the first visit mid-pregnancy, it can be difficult to diagnose hypertension as blood pressures are at their lowest point during this time. It's also important to realize that about 25% of women with chronic hypertension will develop superimposed preeclampsia during their pregnancy. Preeclampsia syndrome is marked by vasospasm and endothelial dysfunction, leading to capillary leak. While some lower extremity edema is normal during pregnancy, severe edema of the feet and legs and swelling of the hands and face are unusual and may be a sign of preeclampsia. Rapid weight gain may accompany the increased swelling. Right upper quadrant pain or mid-epigastric pain may be caused by swelling of the liver capsule. Visual disturbances include scotometer, blurred vision, and double vision. Rarely a patient will develop blindness, which may be due to occipital lobe edema or retinal detachment or infarction. Complaints of headaches and visual changes are important as these symptoms may precede preeclampsia. In most cases, the visual disturbances are not permanent. Pulmonary edema is due to capillary leak in the lungs and can be precipitated by aggressive fluid administration, so it's important to watch the total amounts of fluid these patients receive. Finally, the seizures present with eclampsia are generalized tonic-clonic seizures. There are a number of lab abnormalities present with preeclampsia syndrome. These should be included in the evaluation of women presenting with hypertension, especially if it's a new diagnosis or there's concern about superimposed preeclampsia. I want to emphasize the thresholds listed on the slide are generally used to make the diagnosis of severe preeclampsia. Less severe disease may have smaller or absent lab abnormalities. During pregnancy, there is a disproportionate increase in plasma volume compared with red blood cell mass, leading to a fall in the hemoglobin and hematocrit. The normal hemoglobin concentration in the third trimester averages 12.5 grams per deciliter. Because of vasospasm and interstitial leakage of plasma in preeclampsia syndrome, hemo concentration is a common feature. Seeing hemoglobin and hematocrit results that would be considered normal in the non-pregnant adult may be an abnormal finding in pregnancy. Another feature of preeclampsia is microvascular coagulation, which leads to thrombocytopenia. In general, the lower the platelet count, the higher the risk for maternal or fetal morbidity and mortality. The glomerular filtration rate is increased by 50% in normal pregnancy, leading to typical serum creatinine values less than 0.8 milligrams per deciliter. Protein excretion is also increased in normal pregnancy, up to 300 milligrams per day. Renal perfusion and GFR are actually reduced in preeclampsia, leading to elevated creatinine levels and the presence of proteinuria. Liver transaminases can also be elevated in preeclampsia. Alkaline phosphatase is produced by the placenta during pregnancy and will be routinely elevated and therefore is not a marker for preeclampsia. It's important to use the right size blood pressure cuff when taking blood pressure. Patient position is also important. Many people have been trained to repeat the blood pressure measurement with the patient lying on their side if the initial reading is elevated. This is not appropriate. The goal is not to obtain the lowest possible blood pressure, but to get an accurate assessment of what the patient's blood pressure really is. Typically, 2 elevated blood pressures taken 4 hours apart are required to confirm the diagnosis of hypertension during pregnancy and the postpartum period. However, severe range blood pressures need to be addressed immediately and treatment initiated within 15 minutes if persistent. Why do we want to address severe hypertension and severe preeclampsia so quickly? The consequences for the patient can be devastating. Renal impairment, including the need for dialysis, is possible. Pulmonary edema can require mechanical ventilation and an ICU admission. Severe hypertension, especially severe systolic hypertension, can cause hemorrhagic stroke. If that happens, half of the women will suffer permanent disabilities, while the remaining half will die. Eclampsia is also associated with significant maternal and fetal complications, including placental abruption, neurologic deficits, aspiration pneumonia, and cardiac arrest. There is about a 1% risk for maternal death with eclampsia. There are 3 primary medications that are recommended for use in controlling severe hypertension during pregnancy. The first is hydralazine, a vasodilator. The initial dose is 5 to 10 milligrams, given IV over 2 minutes. If the blood pressure is just over the threshold, 5 milligrams may be used. But if the systolic blood pressure is significantly above 160, then you may want to start with a 10 milligram dose. The blood pressure should be repeated in 20 minutes, and if still found to be high, then another dose of 10 milligrams should be given. Reflex tachycardia and palpitations are common side effects. Labetalol is an alpha and beta blocker. The initial recommended dose is 20 milligrams given IV over 2 minutes. The blood pressure should be repeated in 10 minutes, and if still elevated, a dose of 40 milligrams IV can be given. Maternal hypotension and bradycardia are side effects. If you are concerned about the use of a beta blocker because of other medical conditions, then this drug may not be a good choice. Finally, oral nifedipine, a calcium channel blocker, is another option for treatment, especially when IV access is not immediately available. The initial dose is 10 milligrams orally of immediate release preparation. It's important not to administer the medication sublingually or have the patient chew the pill, as this may precipitate severe hypotension. The goal of therapy is to reduce the blood pressure to safe levels in the range of 140 to 150 over 90 to 100, and not to decrease to normal levels. Dropping blood pressures to normal may decrease placental perfusion and lead to fetal compromise. Diuretics are also not used for the management of hypertension in the pregnant patient for this reason, although they may be indicated for the treatment of pulmonary edema. If treatment for severe range hypertension is given, the OB provider should be notified to manage ongoing therapy. We already discussed the consequences of eclampsia for patients. Magnesium sulfate is the drug of choice for both the prevention and treatment of eclamptic seizures. Studies show magnesium prevents recurrent seizures better than phenytoin and diazepam. A 4-gram loading dose is given intravenously over 15 to 20 minutes and is followed by a 2-gram per hour maintenance infusion. During the initial infusion, you may see a transient decrease in blood pressure. Patients may also complain of flushing or nausea. Some women will experience improvement with headaches with magnesium therapy. Although magnesium is cleared by the kidneys, toxicity is not seen with the loading dose, even with renal dysfunction in the setting of severe preeclampsia. Magnesium levels can be checked every 4 to 6 hours, with the target being 4.8 to 8.4 milligrams per deciliter. Some labs measure magnesium levels in milliequivalents per liter. The target in that case is 4 to 7. In the setting of renal compromise, the infusion can be reduced to 1 gram per hour or discontinued totally if necessary. Treatment with magnesium should continue for 24 hours following delivery. You can clinically monitor a patient for evidence of magnesium toxicity by checking deep tendon reflexes. Loss of DTRs is an early sign and precedes respiratory depression. In the event respiratory depression occurs, 1 gram of calcium gluconate or calcium carbonate is given IV and the infusion is stopped. Postpartum hypertension is usually present in women who have a history of hypertension during labor and delivery. However, 8% of women with preeclampsia will develop hypertension de novo in the postpartum period. The same medications can be used for blood pressure control. Concerns about placental perfusion are obviously no longer an issue. A diuretic may be of value in these patients, especially if there is still significant peripheral edema or you have evidence that the patient has not had much weight loss since delivery. If severe preeclampsia is present, then seizure prophylaxis with magnesium sulfate should also be instituted. Thanks for listening today and for helping us take care of these patients.